moving things from live in person to being on Zoom. I'd like to start today's presentation just in line with the Truth and Reconciliation Commission. And in the spirit of reconciliation, I want to begin this presentation by acknowledging the land on which this session was organized. We are located on the traditional unceded territory of the Algonquin and Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial, and I'm grateful to have the opportunity to be present on this territory. As a settler, I want to recognize the contributions and historic importance of Indigenous peoples, and to recognize that our standard of living is directly related to the resources of Indigenous people. As a settler, my personal commitment is to continually reflect on my own privilege and engage in ongoing learning. And now I want to pass the baton, so to speak, to Judith Allenson. Both Judith and I are, as are some other people that are here as participants I know, are members of the End of Life Choices Committee, which has helped to coordinate the session today. And so with that, I pass it to Judith.
Thanks, Maxine. It's my pleasure to introduce our two speakers, Lisa and Jennifer. Lisa Sullivan is the Executive Director of Hospice Care Ottawa, and she led the integration of 2 hospices in the city to form this organization in 2013. Subsequently, she's overseen the building and opening of a 3rd hospice, the Ruddy-Shenkman Hospice in Kanata, and the expansion of Francophone hospice programs in Ottawa's East End. She's a registered nurse by training with a Bachelors of Nursing Science and a Masters of Public Administration from Queen's. And she spent most of her career in public and population health. Jennifer Lockyer, our second speaker, has been with Hospice Care Ottawa since 2013, and she's currently the Manager of Community and Volunteer Services. In the past, she's worked within the community support sector, coordinating programs such as Meals on Wheels, transportation, and day programs for seniors and adults with a disability. So welcome to you both. Thank you for taking the time to speak today, and we look forward to hearing more about Hospice Care Ottawa and your palliative care programs and services. Over to you.
Great. Well, thank you so much. And
Lisa, you just hit your mute button by accident.
there you go. Did you hear any of me, or?
No, please start again.
Well, I'll start again. I just wanted to thank you all for having us here today, and we really look forward to having the conversation. And although we're going to be presenting in this new sort of Zoom world, it's harder to be informal and have those back and forth questions. I hope you do take advantage of the chat room and ask us questions as we go along. Both Jennifer and I are trying to work out ways to work with our community partners to ensure that the services that we provide are open and welcoming to all groups, including diverse groups, Indigenous groups, LGBT groups, because how important it is that everyone has access to those services. And so the conversation today, as I said, is a conversation, and we look forward to having a discussion with you. I'm going to start by just giving you a bit of an overview of what hospice palliative care is, what we do, and Jen's going to go in specifically to some of the programs and services we have. But like I said, please stop us, or there'll be lots of time at the end for questions as well. Before we do, though, we have a little quiz or a poll, which is just a few questions about myths and facts about palliative care. And I often like to use that at the beginning of a presentation just for fun, because there certainly are a lot of myths out there, and that we hope by the end of it, when we come back, we may have dispelled some of those myths. So I'm going to turn it over to Glenn to see if he can put that poll up for us.
I think we have a bit of a tech problem because we have 2 people logged into our OSPN account, and because of that, I can't start the poll. So Donna, I'm going to ask maybe if you sign out and then and sign into your normal account, and then I'll try and start the poll. Sorry about that.
Too many leaders. We've got 6 already.
Well, here's what I'll do, because it doesn't have to be in a poll. That was just for fun. What I'll do is I'll present the questions to you. And if you have a piece of paper, maybe you could jot down whether you think that's true or false. And then we'll, as I said, hopefully answer some of those questions during the session today. Some of them may be obvious and some maybe not. And then we can review it at the end. So the first question is, palliative care is about quality of life. True or false? The second is, hospice is a place you go to die. 3, palliative care means there is no hope for me. 4, narcotics are used in palliative care to hasten death, speed up death. 5, most Canadians die at home. 6, palliative care can be provided anywhere. 7, talking about dying causes stress for my family and loved ones. 8, I have let my loved ones down because I could not care for him or her at home. And 9, everyone does have access in Ontario to high quality hospice palliative care. Okay, so just keep note of that. And as I said, I hope we address some of those. Now, Glenn, I see you have my slides up. So do I turn them or do you? Do I need you to flip them? Oh no, I can do it. Never mind. Okay. I'm going to start my presentation with this cartoon. Some of you may have seen this before, but I always like to use this as a way to define for people what is hospice palliative care. And in the cartoon, of course, Charlie Brown is saying, someday we're all going to die, Snoopy. And Snoopy says, true, but on all the other days, we will not. And I think that is the most important message about hospice palliative care. Hospice is not about looking after people dying. It's looking after people before they die and they're living. And that's a lot about what our services are about. Our goal is to improve the quality of living and dying, improving people's sense of well-being, and making the days before death as high quality and meaningful as possible. Next slide. Okay, so just to expand on that a little bit, when we talk about hospice palliative care, it is that philosophy of supporting people in living and dying. And hospice doesn't necessarily mean it's a place or an organization. It is the type of care that comes to people. We like to think of hospice palliative care as being family and patient focused. So the focus of care is on what do you need as a person or as a loved one to ensure that you're getting the best care possible. And it is about taking into account all aspects of people's well-being. So that physical, spiritual, emotional, and psychosocial needs. I mean, we know that sometimes at end of life, particularly physical needs are great, but we also know for those of us who work with people at end of life or in palliative care that often the emotional and the spiritual are as important or more important to helping people live that quality of life. Hospice palliative care is also really an intersection between community care and healthcare. And what I mean by that is healthcare in the traditional sense, we do think of the medical care that someone might need while they're trying to live at home or while they need help with pain control. But the whole philosophy of hospice palliative care is that it's not, as I said, a place or an institution, but it's a community. And so you'll see in our programs in hospice palliative care that we work with over 1,000 volunteers, and volunteers are trained to work within communities, to work within neighborhoods, to support people who are living at home to stay at home as long as possible. Next. Sorry, I don't know how to make it go forward, so I have to wait for Glenn.
Yeah, we are on the next slide.
There we go.
Okay, great. Slow on my end here. So just a bit of background for those of you who might be interested. I always thought this was quite interesting, that the modern day hospice, as the term hospice, was really developed by Dame Cicely Saunders, who was a nurse, a physician, and a social worker, as a matter of fact, writer and founder of the hospice movement, really the modern day hospice movement in England. And she developed St. Christopher's Hospice. And I think why that's important is in the 60s, of course, we all who've been through this medical system for years, the 60s, the healthcare system there and here was really focused on fixing people up and getting them out, right? It was, we had a younger population, and hospitals were meant not for dying, but for fixing. In some ways, that mentality still hangs on. But what her initiative and her movement really sparked is that people deserve that same high quality care, whether they're fixable or not. And her famous quote is that you matter because you are you, and you matter to the end of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. So that's support during that palliative period. I also like to mention Balfour Mont, who some of you may have heard of, who's a Montreal physician who's still alive, actually. And he's been known across the world because he really coined the term palliative care. The word hospice in French can have a negative connotation. At one time, hospices were, I don't know if they were sort of places of ill repute or just areas where people went who didn't have a home or a place to go, but they weren't the same connotation that we have now of a hospice. In French, hospice can still have that negative overtone. So Balfour Mont coined this term palliative care, which in French is soins palliatifs, which has that dual meaning. So to try and get away from sort of any negative connotation of a hospice and create that term that makes us feel safe and welcome, and a hospice being a place for everybody. And so you'll hear the term hospice palliative care used together for that particular meaning. Next. So just share with you as well that when we're talking about what hospice palliative care is, we're not talking, as I mentioned, about just dying. And in fact, what we know about hospice palliative care is that the earlier people have access to palliative care, the better they do, not only from a quality of life, but often in a quantity of life. And this is the model that has been replicated again across the world from the Canadian Hospice Palliative Care Association to really demonstrate that the kind of the trajectory of palliative care. So that early on, when somebody might be diagnosed with an illness that doesn't require, or that is not going to be curable, that the important thing we do in palliative care is support, it's advanced care planning, it's ensuring great quality of life, and that very little medical or health care is required. And as disease progresses, which is the top of the triangle, more care and more services are needed as we move into the dying process. But palliative care doesn't stop there. Grief and bereavement support is considered a really key part of palliative care. And so the care that we provide and in hospice palliative care continues through to support those who have lost someone that they have cared about. Okay. So why do we need it? I mean, hopefully that we're all in agreement that we all believe that quality care is a right and that we should all receive that quality care, whether we're fixable, as I said, or whether we're in our last years, days, weeks of life. And that's it's an important part of the healthcare system. And certainly our population is aging, we know that. Whether we like to hear it or not, the chances of dying are much higher when you're older. So we are going to have more people needing more services as our population ages. And despite the fact that we've had significant progress in advancing local hospice palliative care services, there's still limited and inadequate services in a place like Ontario and a place like Ottawa. Over 75% of people would prefer to die at home, but unfortunately over 60% of people still die in hospital. And most people, as I said, would like to be able to die at home, but we know the majority of people cannot access those services at home. You'll learn when Jen talks that while we provide hospice care in our residents, that's a small proportion of the population who access those services. We try to make the residents as home-like and supportive as possible for those people who can no longer continue to be at home for all kinds of reasons. It could be financial, it could be medical, and it could be family burnout. But so that's why we provide those services. But again, most people would prefer to die at home if we could have those services available, and we just don't. And we certainly don't have enough residential hospice services available. We have a city the size of 1 million people, and we should probably have 10 beds per 100,000. And of course, we don't have near those number of residential beds in our community. We have 21 beds here at Hospice Care Ottawa. We have beds with the Mission for the homeless and street involved, and we have beds at Rogers House for Children, but that doesn't nearly meet what would be required for not only our population now, but as I said, with the population aging. And the other consideration, of course, is that not only is our population aging, we're living longer with chronic illnesses. Diseases that we used to think were completely life-limiting are really becoming chronic illnesses, like many of our cancers. And so that support, palliative care at home, is increasingly important. The other point I always like to mention is that really the kind of care that we can provide, or kind of care that hospice palliative care provides, is really very cost effective. And we were all waiting with bated breath yesterday when the budget came out from the province, hoping that there might be some funding change for us at hospice, because we are the only health organization in the province who provide direct health care, who have to fundraise for that care. So our clinical care, we do have to fundraise for. But if you look at the cost of somebody who dies here in one of our hospices, the cost is about a third of a cost of dying in a hospital bed, and usually much preferable. So a hospital bed in a regular acute care bed is about $1,200 a day, plus. And a hospice bed is more around $600 a day. So from a cost perspective, it makes a lot of sense. And of course, the work that we do in the community, we believe, really helps to keep people at home longer. And so we avoid those emergency room visits, we avoid those hospital stays where possible. COVID has really brought a lot of this to the forefront, of course, and hospitals have been overrun, their acute care and their ICU beds, and we've hopefully been trying to make that case that there's a role, much bigger role for places like hospices, where we can care for people at end of life in a higher quality, sort of more relaxed and cost-effective way. Anyways, we didn't hear anything in the budget, so we're still hoping, but we'll hear more about that. Okay. Now, I'm hoping someone's keeping an eye on the chat room, because I can't see it while I'm presenting. So if there is anything, hopefully you can let me know.
I'm keeping an eye. There's nothing there at the moment.
Okay, thank you. So who are we at Hospice Care Ottawa? We are community-based, we're nonprofit, and we offer those palliative and end-of-life services to people living in the city of Ottawa. And we have really made an effort, as I said in the beginning, to focus on trying to increase the diversity of our staff, our volunteers, and our outreach to groups to become more inclusive. I think some of you have been around Ottawa for a long time. The Maycourt site, which was our original hospice, did have sort of a reputation of a very sort of white, what would I say, white, high-income ladies convalescent home, which it was actually. It originated as a convalescent home. However, the hospice, it became the hospice at Maycourt and then eventually Hospice Care Ottawa. And we really are striving to be more representative and welcoming, as I said, to our community. Click there. So in 2020, we did develop our new strategic plan, which I'll just share a little bit with you. And of course, we had great plans for a number of strategic projects, which all got put on hold thanks to COVID. However, we have been plodding away at a few things. I've already talked about our mission, but I think it's important to reiterate our philosophy of care. As I said in the beginning, that the philosophy of care is really centered and focuses on physical, emotional, and spiritual comfort, and this notion that we are welcoming the diversity within our community. The other thing that's important about Hospice Care Ottawa is that all of our services are provided at no charge to our clients and our families. So it is accessible to all. And we do provide support at home, as I said, as well as in our 24-hour residences. So the next slide focuses a little bit more on what our strategic priorities are. And I know it hasn't come up yet, but I'll just go ahead and talk about the 4 key strategic priorities for this plan. The first focuses, of course, on our exceptional client and caregiver experience. And we're really working hard. We've established a patient advisory committee, which we call the Circle of Caring, where our emphasis, of course, has always been on the quality of our care. We are looking at a strategy around strengthening our community involvement. And for those of you in the healthcare field, you know there's a lot going on with the current Ontario government and the development of the Ontario health teams, which will have a big change in how we offer health services in our community. And so we have been staying as intimately involved with that development as we can for the City of Ottawa. Increasing access to hospice services. This is partly what we want to talk about today, sort of the increasing diversity piece, looking at ways that we can work within the community. It also includes things like MAID, which is medical assistance in dying. And while MAID is not considered part of our hospice palliative care philosophy, and it is not something that we would provide as care providers, it is a human right and it is a legal right. And so for those reasons, we do allow MAID on site by outside providers. If somebody is part of our residents and are requesting MAID. We find we have very few cases of requests for MAID, primarily, I think, because when you are receiving hospice palliative care services, we like to believe that the care is exceptional and that gives people time and they're not in a hurry to bring on their death, but we do allow it. And then the fourth area is around ensuring financial stability and sustainability, which Jen will talk about in a bit, but the fact that we are not funded like other healthcare providers makes it very challenging, and we do have to fundraise well over $2 million a year just to operate. That's not to get anything different or special. So if you can flip to the next slide, please. Doesn't seem to work very quickly. I don't know if you guys are seeing the next slide or not. I wanted
delayed for you because I flip it right away, but I guess it's a little bit of a delay.
Okay, so you have it. I don't have it in front of me yet, but we really wanted to, as I said, this conversation today, talk a little bit more about diversity and inclusion. And really, oh, I'm missing something. Find ways that we might be able to work together to help us with this. So our goal this year, which has been hampered a bit by COVID and financial reasons, is to increase accessibility of hospice and palliative care services, to ensure that hospice and palliative care services in Ottawa are delivered free from unconscious bias, and to increase our capacity to work with different communities. So I'll get you to flip to the next slide. So some of the things that we've been working on is first and foremost, some education. And we see the whole diversity strategy. It's not just a one-shot deal. It's not do an education session and it's over. Of course, it's a process. We have in the past been fortunate to have some sessions delivered by your organization, training our staff and volunteers on issues related to LGBTQ. We have recently been working with Nahid Tassami, who some of you may know from Toronto, who works with an organization called Amplify Health, who looks really at structural vulnerabilities and some of the inherent equity and inclusion, racism issues related to that. So we are going through a long series of training there. We certainly continue to work with our staff, particularly around multicultural traditions, because we do, of course, have people from many different cultures, and we have tried to set up sacred spaces within our hospices that have objects that relate to a number of different cultural or religious traditions. Thanks to Kathy and your group, we had a letter to support us in a funding grant from Heritage Canada, which we're really hoping, we still haven't heard from it. We're really hoping we get some funding for that, because that's really the only way that we can really expand the work that we do. And what we're hoping to do there with the Heritage Canada grant is really identify a couple of key communities in Ottawa and really work with that community to develop a strategy for addressing hospice palliative care. So not so much to sort of promote, hey, this is what we can offer you, but more about developing together what it is a particular community would like, need, whether that includes training volunteers, whether that, includes translating brochures, could be anything, really a community development approach. And we really need that funding to be able to do that. And if we could pilot that with a number of communities, then that might help us to continue to develop that approach with others. We have, for example, just as an example, worked with the community of the deaf community in Ottawa, which is we've been working with the deaf community for a number of years, and it's been a really interesting process because the deaf community are very connected to each other. And so through their connection with us, we have trained a number of volunteers, and a number of their community have trained to be volunteers with us, but they actually look after people within their community. So those who are dying and supporting those at home as long as possible, and have had the supports and the resources that they need to do so, which I think is a really great example of a way that we could work. We're continually trying to work on updating our policies and procedures and forms. I think after one of the presentations from your group, we got a little attuned to the fact that our admission form, for example, just asked whether you were male or female, which I'm sure, it's obvious now, but a few years ago, it never, nobody thought about it in our organization. And that helped us to sort of re-look at what kinds of questions are we asking, and how welcoming and how easy are we making it for people to self-identify if they choose to, whether it's a culture or not. And then, of course, we want to continue to review and our materials, not just our policy, but the materials that go out to our community and to social media. So those are, certainly some of the areas that we're really hoping to work on a little bit more as part of this diversity project. And I hope when we come back to have our conversation at the end, I'm hoping you'll have some ideas as well. I'm going to turn it over to Jen now, who's going to talk a little bit more specifically about some of the specific programs and services we offer so that you have a little more familiarity with it. Thanks. You got it, Jen?
Yeah, thank you, Lisa. Lisa, you're the only one I see. Can you nod that you can hear me? Oh, there, I've lost you anyways. I think you can hear me. Anyhow, so Lisa did talk about our residential services. So I'll just quickly reiterate. We have 21 hospice beds located between two sites, one the Maycourt site and our other site here in Kanata, called the Ruddy-Shenkman Hospice. And really, people come to us sort of, we say the last days to weeks of life, particularly if they're, not coping at home, or their caregivers are struggling, or, they need to move for whatever reason. They come and receive support here through our nursing staff and our volunteer team who are here 24 hours. We also have our community programs, which people, can access a lot earlier in their diagnosis. And so, for instance, we have an in-home support program where we match somebody with a volunteer. Often we find some similarities, some like-mindedness once we learn about the client and we know our volunteers very well, and we're really good at making some great matches. And this volunteer goes in, can help in the home once a week, and with some practical supports. They can help with errands if the person's well enough to go out and do some errands. But also in home, sometimes some of the practical things are, organizing some of their affairs, writing letters, cards to their grandkids, for instance, and just different things like that. But we also just are there to provide social and emotional support. We're a non-medical visit in a world where people are, visited often and have many medical appointments. So it's one that somebody's just sitting down, able to talk and spend a couple of hours with them, usually 2 to 4 hour visits weekly, and really develop that relationship. And from there, the volunteers often come back to us, and we can advocate for things that are maybe missing in that person's life, or services that they may need, and change the trajectory of how things are happening at home. We also have a day program where people can come to us who are living in the community with a life-limiting illness. They come to us. There's usually about 12 to 15 other participants on any given day when COVID's not here. And they have spent the day together supporting one another, but they also receive support from a staff member and other volunteers, trained volunteers. They receive a hot lunch. There's complementary therapies such as Reiki and massage they can take advantage of. They often do art, music, games. There's also times when we can do meditation and relaxation. And there's always an area where if somebody doesn't want to be in the group, that they can go off on their own, maybe with another volunteer, or even have like a nap or a sleep on their own. Those two programs greatly benefit caregivers. Often when the home support volunteer comes in, the caregiver goes out. And of course, our day program, we pick the person up at their home and bring them home at the end of the day. So it gives that caregiver, almost a full day's break. Our other programs are, within all our programs, we have a family support team of counselors who not only connect with the person who has the diagnosis, who has the illness, but their family. Their main caregivers, their main loved ones. And actually, family is a broader term. It doesn't have to be like a blood relative or a spouse. It's who is that person's caregiver and who is in their circle right now. And that's who we're going to care for and provide support to. And then our other things are often, or always, our clients' families receive an opportunity to receive bereavement services, like support groups, drop-ins, a grief and bereavement walk, and sometimes even some one-on-one individual counseling if there's a need. So you can flip that slide for me. But those are our main areas. These are our locations. We've spoken about Maycourt and our Kanata location. but we're so pleased to have opened a Francophone, a French location at Maison de l'Est in Orleans. And it doesn't have any hospice beds, but we host a day program there in French, and we host our in-home support services from that location as well. I'm going to pop, you can change the next slide. It's just pictures of our variety of volunteers. Lisa already mentioned we have almost 1,000 volunteers, and they give a lot of their time, 50,000 hours a year on average, which we do say that if it wasn't for volunteers, this organization, wouldn't be able to provide the care that we provide. It's the equivalent of 30 full-time equivalent workers. And as Lisa mentions, funding's not growing to hire that many people. So we just really wouldn't be able to function. So this is just some pictures. The top corner under volunteers, that's actually our Ottawa Deaf Healthcare team and some of their members that they support at our Maycourt location. And they were doing a butterfly release that day. Under that picture, the second one under the word volunteers is a group at our Maison de l'Est site. And that is a group of volunteers who were trained. The other volunteers, you can see some of our therapy dogs. We have gardeners, people that take care of our house and gardens. And we have a community outreach team who goes to community events, tries to spread the word about hospice palliative care, but also we're available to do presentations just like we're doing here today to anybody who requests it. Thank you. We can move to the next one. So the next one is really, what our clients are saying about us, what kind of services they have. And it's overwhelming that 97% of people who receive our services report that they're receiving the care that they need. They're very satisfied with the care they receive. The top one is particularly a survey from our day hospice clients, but the bottom one is more in general. But more importantly, other than the numbers, it's what people are telling us. So the quotes there read, "Thank you to the staff and volunteers at our beautiful hospice for the kindness and care they offered my mother, and the support and encouragement they offer all of us." The other quotes in the middle say, "You became our lifeline during the most difficult time of our lives." And the last one is, "Little did I realize when I was diagnosed this year that a whole group of wonderful and caring people would stand beside me on my journey. You are truly remarkable people. I feel so welcome and inspired by your care." The next slide, I was going to talk a little bit about funding, but Lisa did, so that's wonderful. The one thing I do want to talk about is our fundraising. So we've heard that the government does support us at just under 60%, and so that means we do have to fundraise, about 2.2 million, like Lisa said. We do that through our events, through mail campaigns. We have a membership. We get a lot of donations through in memoriam. After somebody dies, their family, or they might leave something for us, and or the family may ask for donations at the funeral. And of course, we do apply for grants, as Lisa was mentioning. The Maycourt Club of Ottawa is one of our greatest supporters. They actually offer our location at Maycourt. They offered that to us at free of charge. So we're there rent free. And that's where 9 hospice beds are, 3-day programs around all our grief and bereavement services, in-home support, all of that. And they also give us money to pay some of the bills for that building a year. So they're also a big help. The next diagrams, when they come up for you, they're just pie shapes. And really, the big one is, I want you to see under the expenses is, out of all of our money that comes in, 77% of money, and it's mostly donations, go directly back into programs and services to benefit our clients. We have a very small budget for administrative and management. and a small budget to help us fundraise. At the pie to the left is just different types of donations that we get, which we talked about. A lot of support there in the gray from service clubs and churches and things like that. Thank you. The next slide just shows us what we've had to struggle with for fundraising during COVID, and it meant that we had to do everything virtual. So I just want to plug that Hospice Care Ottawa has the Hike for Hospice coming up here in May. And it is one of the virtual events that has been really successful because people don't mind registering and signing up and hiking with their loved ones around their house, around the whole community. Last year, of course, this is going to be our second year hosting it virtually. And a lot of people, as they were hiking, took selfies of them. And it was up on the Facebook pages and things as the day went on. So it did feel like a little bit of a community event. So, yes, I just wanted to plug that next one. So our next slide really says wrap up, and we have questions on there, but also, like Lisa mentioned in the beginning, we would like to open the floor for discussion as well, and thoughts and open discussion about our organization, but also learning from you how we can, we can be more inclusive. Maybe you've heard of stories in the community and things like that. So I just welcome your questions and your dialogue as we move into that. So I'm not sure if you want to turn off the slides to start that conversation, because I think right now you're only looking at me. But
it's a good idea.
Yeah.
Okay, thank you. Because I think the other thing is certainly it would be if we can go back to those original myths and facts and see if anything surprised anybody about that, or if they've changed their answer as a result of the as a result of our presentation today. Probably everyone realized that palliative care is about quality of life. So anybody have any comments on that? Was that new or different? Did you think hospice was a place you go to die? Okay. I don't need to go through them one by one, but I'd be interested to know if anybody had any comments about these sort of revelation, anything different.
I think I had guessed that people still died at home more often than they died in hospital, but you disabused me of that notion during your talk, Lisa. Yes.
Yeah.
60%,
Surprising.
I think you said. Yeah, it is surprising. Yeah.
And especially it's such a disconnect because most people we know want to die at home.
Yeah.
Now, COVID has changed things a little bit, actually. So it'll be interesting to look at the statistics once COVID is over. But we found over the last year, people in general have been very hesitant to go into any institution. So they didn't want to go, if they weren't, if it wasn't COVID related, they didn't want to go to the hospital. We know they didn't want to come into the hospice. But what happened as a result of that is that we saw people very late in their trajectory. So instead of coming in 2-3 weeks ahead of time, they came in crisis, which isn't always the best, right? So it's tough. It's been tough for people. And there's been a real dearth of services at home. So caregivers have really taken the brunt of this, family and friend caregivers, right?
Right. Yeah. I think we've got enough. Well, we've got a reasonable size audience that people can just speak up rather than using the chat function. I don't think we need to monitor chat. We could just have a dialogue. I've got a number of questions about the resource figures that you've provided. And I suppose the first one is about that ideal number of hospice beds when you talked about 10 beds per 100,000. So we should have 100 beds here in Ottawa, and we have 20% of that, I guess. Is there a lot of variation around the province? Are some people better off in terms of the number of beds than Ottawa is? Or would you say that that's how the landscape is in Ontario or even across the country?
We've pushed very hard in Ottawa, so I would think we're doing probably better than most places. Certainly Toronto, Central Toronto has probably a higher concentration of hospices in smaller areas. So, but of course they have a much bigger population. Northern Ontario and rural areas, they're really very limited.
Yeah.
Yeah.
Yeah. And when you talk about 50,000 hours of service, which sounds very impressive, and yeah, absolutely. And you also, the other statistic that I was interested in, which is the one you've just mentioned and which I've heard before, that hospice care, sort of in hospice care, is often the last 2 to 3 weeks of life. So how do those 50,000 hours look? I mean, I guess what I'm asking is, at what point do people tend to be in touch with you? In which part of their journey towards end of life do they tend to get in touch with you? And at what point are you able to provide those hours at home or with respite care for caregivers on that journey towards the end of life, and perhaps then being in a bed in a hospice?
Yeah,
Is that clear?
that's a really good question. So, we tend to think of our programs a little bit separately, though that they do connect. Our community programs, anybody at any time in the community can contact us for support at home we do an assessment through one of our professional staff, and then a match with a volunteer, or that person may go to day hospice. And in a non-COVID year, we'd probably be looking at 1,500 clients, Jen, off the top of my head, in the community being followed at any one time.
1,500, wow.
Yeah, including all the day hospice programs. We have 3 at Maycourt, we have 2 at Kanata, we have 1 at the East End. So, that's the kind of numbers that we're looking at in grief and bereavement. In the residence, because of our beds, because of our limited number of beds, you're right, we can only take people in the last weeks of life. So unfortunately, I think personally, I feel that people could benefit from a longer time in hospice, but we just don't have the resources. So we have to limit it. And so by the time people come to us, yes, they are usually pretty ill. And so the care we provide is very often sort of physical care for the client, but a lot of emotional support for the families. And we see about, with our current beds in a non-COVID year, to always qualify that, about 360 people a year. So I don't know if that answers your question. So
Yes.
in terms of when people access our service, again, the community program, anybody, anytime can do that. And we encourage them to do that. Because a lot of what our community nurses will do is refer them to other community support services. Maybe Meals on Wheels they need. It may be, there could be lots of things that they need connections to, and our nurses tend to do a little bit of that navigation. People are first hit with a diagnosis, they haven't had to access services before. The home care coordinators come in and say, oh, you're not eligible for nursing care, right? So then you're left. So that's often what we do, and stay in touch so that we can sort of support them as they move along their trajectory. For people to be referred to the residents, there is a specific referral process, and it has to be by a healthcare professional at this point. So it's the nurse in the home, it could be the family physician, it could be the nurse in the hospital or the social worker, and it goes through a triage. So we work with Bruyere Continuing Care and what used to be LHIN CCAC, which is now called Home Community Support Services, I think. So that when patients are referred for end-of-life care, we look at what the needs are and where the most appropriate place is. The palliative care unit at Bruyere does offer really good palliative care. It tends to be for more acute situations, people who need a lot of medical care, or they're still undergoing treatment. Whereas when you come to hospice, you've really made that decision that your goal of care is to be comfortable, and we're not treating. So the decision is made at that point, and then people are offered hopefully an appropriate bed.
Right. How many additional beds would there be in Bruyere?
Well, it's a bit floating, but right now they have 30 what they call PCU beds, palliative care unit beds.
Okay.
But it goes up and down depending on what the demands are. Like right now, I said right now, but I meant before COVID. During COVID, half of those beds I think have been gone over to COVID patients.
Okay. I've got lots more questions, but do other people have some?
Yeah, please throw them at us.
Maybe I'll just say, I think there are a number of us that have had experiences looking after a friend and a group environment with other friends. And, you know, I feel like one of the things that was really missing was somebody to kind of help us navigate through that process. These were people who wanted to remain at home as long as possible, maybe until the very end. But it sure would be helpful to have somebody to help. Like, do you ever give support to a family group or a group of friends who are around someone who is in that kind of dying process?
I think that's what we would love to be doing. Certainly our community nurses in the community program, because we're not all that well known, sometimes we don't get called in until a little bit later, but what the community nurses will tell us, and I'll let Jen jump in, is that they often spend the majority of their time working with the family and friends on sort of either navigating the healthcare system or coming up with a plan about how we're going to get meals and, you know, washing and all those things done. Like, they do a lot of that sort of as part of the caregiver support. I think it's a critical role. Kathy knows that I had my own experience when my husband died, and I couldn't have survived if it hadn't been for my friends who really supported me. And it's always made me feel very passionate about that role. So I think that is something that we would love to do more of. The volunteers, of course, then are there as an extra person, and I think they often support that as well. Jen, do you have anything to add to that?
No, I know you had said what I was going to say, but so the nurses check in at least once a month, but can take a call anytime and really try to support I want to say the care group, because it's not always like you say, it's a friend. It's not always necessarily like a parent or a spouse or something. And they figure out who the main person is to contact, and they can provide all kinds of resources and support. And they're also the link to the LHIN coordinators, which is not called the LHIN anymore, but the care coordinators. And so they do a lot of that navigational support. But the issue is, oh, sorry, I was just gonna say, the issue is, like Lisa mentioned, is sometimes people don't get connected early enough to benefit from that type of support.
And what is your relationship? Okay.
I'll just mention before you go on, Kathy, is the other thing that we've done is we've been working with the regional palliative care group and developed some caregiver training. And this is a little different than our caregiver support. It's a practical training, because one of the things that we were hearing is that, yeah, it's great to have the emotional support, but I don't know how to give a bed bath. I don't know what I'm supposed to do to help lift this person out of bed. So people wanted some practical training. So that is available now. And actually, they've just turned it virtual. So that's something else for us to think about. Sorry, Kathy, go ahead.
No, I was just going to say, there is a kind of a community palliative care team that is also like, what's your relationship to that group?
So the community palliative team, meaning from the home care?
Is that where they're from? Home
Yeah,
care?
I think you mean the community
Is that where they come
palliative
from?
team
Okay.
are the nurses who are the care coordinators. So it used to be called CCAC, and then it was called LHIN CCAC, right? And now there's sort of some changes again, but it's the regional home care system, and the care coordinators, people are referred to them, and they're the ones who do the assessment and then set up the care. So they're the ones who would go into the home and sort of, arrange for your PSW to come twice a week. But if the patient is palliative, there's a specialized group of care coordinators who follow palliative patients. But sometimes people aren't eligible. like they're not ready, or they're palliative, but there's
Okay.
you can only get a nurse, a PSW 3 days a week, and you really need someone every morning. You know, these are the issues that people are facing, especially during COVID. Does that make sense?
Yep. Mhm.
If I may, I'd like to follow up on something that Kathy's been talking about. So hypothetically speaking, if there are a group of friends that are helping support somebody, a dear friend who's in the latter stages of life, how do they go about accessing some of those services that you've talked about here today? So when you talk about the nurse and home care, et cetera, like that, I know what the process would be in terms of having to get assessed and everything if you're going through LHIN or whatever it's now called. But are we able to make a direct link with you?
Yeah, you certainly are. I mean, certainly the palliative care, home care nurses often refer to us. So we work very closely with them, but you can call us directly. Anybody can. And one of our nurses, you know, our goal is to respond to calls within 48 hours. So there'll be a call back within that period of time to sort of discuss what the needs are. Though I am intrigued with this mentioning of a group of friends, and I wonder if that's an area that we might be able to work together on, sort of identifying when there's somebody who's in that situation, and how could we work with a group to support them in that care. Jen, did you want to add to that community referral?
Yes. So, I mean, traditionally, I guess, you know, what we would ask is that the caregiver or the friends one spokesperson gives us a call. And then we always want to know, though, does the person that is not well, has the diagnosis, know that we're connecting? Because hospice, we don't want to just make a call to that person out of the blue, sort of thing. So we do go back to that sort of friend group, that if we are going to connect with their person that they're caring for, to let them know and prepare for us to call. We just don't want to go, hi, it's hospice calling. Anyhow, but and then yeah, typically, you know, we have one or two caregivers that we work with, but as well as Lisa, it dawned on me that, you know, sometimes it is a group. It's a caregiving group of loved ones that care for this person and share the load. So, you know, what would that look like? Helping train, helping navigate, helping support. Often there is usually sort of one person who takes the lead on that, and that's probably the person that our nurse would talk to the most, but possibly be available for the others.
I mean, wouldn't it be great? Go ahead.
Sorry. I was going to say, we have talked about this in our committee, end of life committee, about circles of care, have done a little bit of research. And I think this is an area that we would love to work with somebody else on. And I think I would say a good 50%, if not more, of our family situations would be just that, where it's a group of friends around a person caring for them at the end of their life. So that may be a unique aspect of our community even.
Mm-hmm. I really like that idea. I remember in one community I was in, they used to do, I don't know what they called it. I think they called it coffee time or whatever. But basically the hospice person would meet with a group of people who were neighbors, I think, that were supporting someone else, and just have that conversation about what's happening, what can we do, you know, how can we better support the family, but also ourselves, because that's the piece that often gets missed with caregivers, is supporting yourself. Because well, for obvious reasons, burnout is a big one, but just the emotional toll when you're losing a friend or a loved one, right?
Sounds as if that would be a really fertile area for discussion, especially if you get some grant support from Heritage, and thinking about our community in particular.
Mm-hmm.
Yeah.
So I think we could start supporting that without a grant. I mean, I think if you know, we if any of you come across that situation, or maybe we need to write something up as a way to support it, I think that's something we could do right away, or at least try if it would be of use.
Kathy, it sounds like that would be something that the people even in this group, or certainly in our committee, in our community, there would already be people who would be interested in that, right? Yeah. We should stay connected about that.
Sure.
I wanted to ask about interaction with other groups. I mean, I've listened quite a lot to presentations by Compassionate Ottawa recently, and thinking about their volunteer activities with death and dying and grief and bereavement. There's obviously considerable overlap with palliative care and hospice care. And I wonder if there are any formal or informal connections between the groups.
Yes, we are connected. In fact, I'm on the advisory committee for Compassionate Ottawa. So we're still sort of exploring roles. I mean, Compassionate Ottawa has, a big role in advanced care planning, and have volunteers and people who can do that. Because of our funding situation, we tend to have to focus on our clients, if you will, as opposed to the community writ large, not out of necessity. We have been talking about grief and bereavement. Again, our grief and bereavement services are for our clients, and they're looking at some grief and bereavement sort of, again, for the larger community. Though we have been talking, because we are one of the few groups that can now offer the grief and bereavement groups virtually in French. And so we're hoping to have a meeting actually next week to look at collaborating on that, because there's so few resources, we have no time to duplicate. Right? Yeah. There's such a need. So yeah, so we have to keep communicating about it. They're a very passionate group of people, and have done a great job in education. And so our focus tends to be more on the care piece, but there is an intersect, if you will.
Mm-hmm. Okay.
Sorry, there's just one question in the chat that I'd like to bring up. George had asked and mentioned that OSPN has a resource list, and he's curious about adding Hospice Care Ottawa to the list with your permission.
Absolutely. Absolutely. And certainly, I can share with you some resources, but again, our website, we do try to keep pretty current. And so most of our resources are available there as well. And I don't know if you guys have a Facebook page, but you should follow each other.
Yes, we definitely have a Facebook.
I'm trying to get into the social media thing.
I don't actually have a question, but I did want to just make a comment. As somebody who's been a beneficiary of hospice care service, I cannot say enough. In fact, I think one of your 3 little quotes might have been mine, because
really? Oh, wow. I didn't know that.
it sounded like something I may have written, because you were our lifeline, my lifeline anyways. So I can't say enough for anybody that is experiencing somebody that they love being at the end of life, or when it comes my time. I know I would absolutely have no hesitation to connect with hospice care, and to encourage my family members or caregivers to look for support from you. We had my late partner and I, we had a volunteer. That was our first connection to hospice that came to our home. It was probably for about 3, maybe 3.5 months, the last 3.5 months of her life, who was absolutely marvelous. And sometimes I wasn't, and I did leave the house for about an hour while she was there, which gave me time to sometimes go for a coffee next door by myself, which was absolutely invaluable. And sometimes I felt like that the volunteer was, well, I always felt she was as much there for me as she had been for my partner. So, and being a lesbian, the volunteer was whoever well, I know who matched us. She doesn't work there anymore, but it was a phenomenal match, you know, and it worked in every way possible. We were also connected to your, can't remember on your slide now what you called it, but we did, even as a couple, have a few sessions with one of your counselors to help us look and just talk about how as a couple we were dealing with end of life decisions and how it impacts on your relationship, etc. And then I certainly made use of the bereavement pieces after. So I just my own little testimony today to all of those people that were there and supported us. And if you know, I think it's awesome that you're looking at becoming more diverse. I have to say, probably before you even had that as an official umbrella, it was certainly a very warm, welcoming and experience for myself and my late partner. Actually, Lisa, we've met because I'm the facilitator of the ALS support group, and we met once. And I have to say that all of the people in the support group that I've met over the last 3 years who have had family members in hospice, everybody has only talked about what an amazing experience it was, and how you or Jennifer mentioned today that often people come because, you know, they're burnt out or they're really at the very, very end and things are very, very difficult. But one of the things that a number of people have shared with me over the last 4 years actually now has been that the person who was dying actually wanted to go into hospice, and that experience alleviated for the primary caregiver, the spouse, how do I word this? It took off their plate having to deal with all the scheduling, all the making sure meds, if meds were being administered, pain medications in particular were administered. And it really, everybody talked about how it totally freed them to have, in those last few weeks of the person's life, to just concentrate on the relationship and not so much on the caregiving. So I wanted to just add that to everybody here listening to it.
That is so beautiful. Thank you for sharing that, Maxine. I thought you looked familiar, but I didn't want to jump to a conclusion.
You're seeing my COVID hair before.
Oh, there you go.
You might have recognized me pre-COVID with my very short hair.
But I think, you know, your point is so profound, because what we do here is that when you do come to hospice, if you come, I mean, you can be the wife, the partner, the daughter. You don't have to be the caregiver. And, you know, my own experience was before I was even in palliative care looking after my husband, and I'm a nurse. And I just thought, I spent my whole life figuring out, you know, how to manage care and not spend quality time as the mother or wife. So I'm glad to hear, because that is certainly our goal. And it's so good to hear when it's working. Oh my goodness.
Somebody wants Lisa today.
I know, and I can't figure out how to put it off. There we go.
People that are listening to you here are starting to call you now.
Oh no.
The word is out. Okay. Is that what you're saying?
Yeah.
I hope so. I hope so. No, that's very touching. I'm really glad you shared that, Maxine. Mm-hmm.
Great, Maxine. I think that if we started off this presentation with you said it all. And you know, the more you can share your story when in places you're comfortable, it's you know, it really helps people hear the lived experience. Thank you.
Could I circle back to a different topic for a moment, and that's medical assistance in dying, which you brought up, Lisa. And certainly in the early days of the program in Canada, I think many of us, I certainly was very aware of the antagonism between the sort of palliative care medical community and those who were very much in favor of MAID. And I've read a lot since then, particularly from other jurisdictions, but also from physicians, palliative care physicians in other parts of Canada and even other parts of Ontario. And I've kind of got a sense that many palliative care docs have seen the value of MAID, and if even if MAID has not been a procedure that the patient wanted, if they knew that they were that it was available to them, they felt that there was an impact on that person's well-being, and that the resulting response and impression amongst the palliative care docs community was that it was a more positive feeling about medical assistance in dying. Do you get any sense that things have changed? Are people more accepting of that as one tool in the toolkit?
Yeah, I would agree totally. I think when it first came, there was a lot of fear, right? And people sort of took sides, and particularly some of the organizations really jumped to taking a position. Fortunately, I think we didn't take a position in the early days as a hospice, really some good board advice to just wait and see, how things come out. I think it's clear that most people who work in palliative care, while it's a tool, as you say, in the toolbox, it is not, as I said, part of the philosophy of care. So the philosophy of care in palliative care is comfort, right? Neither to hasten death or prolong life. That's sort of what's built into people. And I think that ultimate fear was that was taking that away from them. However, just as you've said, I think one of the most important things at end of life for people is to maintain some aspect of control. Usually people who are suffering, even if it's physical suffering, it usually tends to be existential. It has to do with the fact that they are losing that control, and rightly so. And so that choice about MAID gives, as you said, for patients often that decision. I mean, they can choose, and that I think does help. I think that a lot of our physicians have seen that the MAID process can be a dignified process, and so that fear is sort of relieved. Most of our physicians do not provide the procedure, but we'll do, and are required to do, referrals and assessments for people. So I think, time has really helped that. The other thing, though, in hospice, which is different than providing MAID perhaps in the community, is that we only see patients who are really at end of life. So with the new legislation, there are going to be some opportunities for people who don't necessarily have disease or death in the foreseeable future, right? That part has been taken away. Again, that's not going to affect us particularly, but I think it may sort of challenge some physicians and healthcare providers, again, sort of raising to the forefront that ethical issue for them. It may. And we're also looking at mental health. I mean, that's the other one they're starting to look at in 2025, is it? That'll be, is it 25, 26? Allowing, well, in some fashion, allowing people with mental illness to make that decision. So, I think we're going to hit it again, but right now we're in a place where people are more comfortable.
Okay, thank you.
And, when we first started here, we surveyed people, and we were worried that we would lose donors. We were worried we'd lose volunteers. And when we introduced or revised the policy to allow it on site, we found the difference in 3 years was most people were, yeah, sure. It didn't make any difference. So it's interesting.
Yeah. But perhaps not surprising when something like 87% of Canadians were always in favor of medical assistance in dying from the beginning.
Yes. Yeah. I think in the palliative care community, the concern always was they might be in favor of MAID, but do they even know what palliative care is or can be? I mean, most people have a fear because they haven't experienced what Maxine has in terms of end of life care. So that's always, the issue for those of us in palliative care. Yes, MAID's a human right and it should be available to people, but equally is palliative care, and it should be available to people, right? And so I think that's where we get into this.
That's right. And I think that's why we all feel we should be lobbying for more palliative care, as well as lobbying for the right to medical assistance in dying for the people who want it. Yes, I agree.
Yeah, and that's what was the fear, was that it would get lost, right? So hopefully, hopefully, you know, they'll go hand in hand.
Yeah. Excellent. Are there other questions? I have not got a clock within reach. I have no idea what time it is, but
3:19.
all right. Good. Well, if we're all questioned out, I'd like to thank the two of you very much for taking time to come and join us. It was a great presentation, but it was a really robust question and answer section as well, and I really enjoyed it. I hope that we've cemented a little bit of collaboration in the process of this too, which is a lovely conclusion.
Yes. May I just add that I think as soon as I hear about that heritage proposal, I will certainly let you know. But in the meantime, feel free to connect with me, Kathy, or whoever, if Jen and I can start talking about how we might support a group of friends if there's a situation that comes up. I think we'd love to explore that.
That sounds great. And we probably, as an end-of-life care community or committee, will meet at some point to take that further as well. Then we know we can connect with you with some ideas. Donna?
Yeah, just and you mentioned that practical training now being online. If is that on your website, or can you send us a resource?
Actually, I think they've just done it. So I'll send it to, I guess.
Send it to me or to Glenn. Yeah, or maybe to me. Yeah, that would be great.
Yeah, I'll send you the link for that.
Thank you. Great. Well, no other questions. Thanks so much. Been a very informative and pleasant experience, and I hope it's been worth your while too.
Absolutely. Thank you so much.
Great.
Thank
Bye
you,
for now.
everybody, for
Bye now.
Thank you.
Thanks.
Bye-bye.